Okay, I think we'll start. And hello, everybody. Good afternoon, and welcome to this session. And thank you to the conference organisers for the invitation to contribute to this event. And thank you to the Irish Cancer Society who are facilitating this forum. These are unusual times, but it's fantastic to have the option of being able to facilitate this remotely. And I know Fionnuala is online with me, and she'll be coming in at the end of this session. Please note that this session is being recorded, just so that you're aware of that. I just want to clarify up front that my background is I'm a nurse and I'm a researcher. I'm not a geneticist or a genetic counsellor, but what I'm sharing with you is a perspective on the barriers and facilitators to understanding inherited cancer. And in terms of the session itself, I'm going to give a brief overview of genetics just as a background to understand this session, and then look at the barriers and facilitators to accessing cancer genetic services. So I hope that's okay with all of you. So in terms of genetics, no field of science has changed more or changed the world more in the last 50 years than genetics. Genetics is a branch of biology mainly concerned with the study of genes, the study of genetic variation, and the study of heredity. That is how information is passed from one generation to the next. In scientific terms, hereditability is a statistical concept that describes how much of the variation in a given trait, for example hair color, can be attributed to genetic variation. Hereditability estimates range from 0 to 1. If the statistic is close to 0, it indicates that almost all the variability in a trait is due to environmental factors, with very little influence from genetic perspectives. Characteristics such as language spoken, political preference, all of those have a hereditability statistic of 0 because they're not under genetic control. A hereditability statistic close to 1 indicates that the variability in a trait comes from genetic differences with little contribution of environmental factors. Many disorders are caused by mutations in single genes, such as cystic fibrosis, for example. And these have high hereditability statistics and have very little influence in terms of environmental factors. But there are many disorders that are a combination of genetic predisposition and environmental factors. And these are called multifactorial disorders, and some cancers fall into this context. So there are genetic influences in almost every disease, however. So I'm just talking a little bit about genetics so that we understand some of the commonly used terms when we talk about genetics. And this particular schema here is just a representation to help us understand the commonly used terms. So within the human body, we have about 37 trillion microscopic cells. And within those cells, we have what are called nucleuses. It's like the brain of the cell. And within the nucleus of a cell, we have chromosomes. And within chromosomes, there is deoxyribonucleic acid, DNA. And genes are made up of segments of DNA. So chromosomes are thread-like structures located inside the nucleus of cells. And in humans, one copy of each chromosome is inherited from the female parent and the other from the male parent. This explains why children inherit some of their traits from their mother and others from their father. DNA was discovered in 1869 by a Swiss researcher, Friedrich Michner, when he was studying white blood cells. And you might have heard of Watson and Crick. They characterized the DNA double helix structure, which is the common representation of DNA. And DNA is a self-replicating material that is in every living organism. And in simplest terms, the DNA is a carrier of the genetic information. It contains the instructions by which we grow, survive, and reproduce. So it's a recipe or code for starting point for our development. But it's the DNA's interaction with our lifestyle, our environment, and our nutrition that ultimately forms us as human beings. So genes, if we look at the term gene, genes are made up of DNA, and some genes act as instructions to make molecules called proteins. And every individual has two copies of each gene, one inherited from one parent and one inherited from the other parent. Most genes are the same in all people, but for a small number of genes, less than 1% of our total, there are slight differences between people. And it's these very small differences that contribute to each person's unique physical features. Scientists keep track of genes by giving them names. For example, chromosome 7, there's a gene which is called CFTR, which is implicated in cystic fibrosis. So that's just a little bit of information in terms of genes. So when it comes to cancer, what is cancer? Cells are the basic units that make up the human body. Cells grow and divide to make new cells as the body requires them. Usually cells die when they get damaged, old, and these cells are replaced with new cells. And this is a very orderly process. And term apoptosis is the form of programmed cell death. And cancer can begin when genetic changes interfere with this very orderly process. Then cells can grow and grow uncontrollably. And genes control how our cells work and how our cells make proteins. The proteins have specific functions and act as messengers for cells. Each gene must have the correct instructions for making its protein. This allows for the protein to perform the correct function for the cell. Cancers begin when one or more genes in cells mutate. A mutation is a change. Sometimes mutations create abnormal proteins, or these mutations can prevent the protein's normal functioning. An abnormal protein provides different information than a normal protein, and then this cell can multiply uncontrollably and sometimes become cancerous. So when we talk about gene mutations and how they occur, what is it? A gene mutation is a permanent alteration or change in the DNA sequence that makes up a gene, such that the sequence differs from what is found in individuals normally. And there are two major types of gene mutations. There are hereditary or germline mutations. These are inherited from the parent and are present throughout a person's life in virtually every cell of the body. And these germline mutations are less common. A germline mutation occurs in a sperm cell or egg cell. It passes directly from the parent to the child at the time of conception. As the embryo grows into a baby, the mutation from the initial sperm or egg cell is copied into every cell in the body. Because the mutation affects reproductive cells, it can pass from one generation to the next generation. Cancer caused by germline mutations are called inherited cancers. And these inherited cancers account for about 5 to 10% of all cancers. But the more common mutations are acquired or somatic mutations. These occur at some point during a person's life and are present only in certain cells, not in every cell in the body. These acquired mutations are the most common cause of cancer. They occur from the damage to genes in a particular cell during a person's life. Acquired mutations are not found in every cell in the body, and they are not passed from the parent to the child. Factors that are causative factors in terms of these kind of mutations include excessive intake of tobacco, smoking, ultraviolet radiation, sunlight, viruses. And what we know is that over our lifetime, we can accumulate such mutations. During an individual's lifetime, mutations have to happen often. A mutation may be beneficial, it may be harmful, and this depends where the change in the gene occurs. Many of the mutations that occur are repaired by the body's normal repair system. It is those mutations that escape repair that can cause cancer. However, as I say, most of the mutations are corrected within the body in the normal course of events. But as we have learned over the last number of years through research, that nearly all conditions and diseases have a genetic component. And we're really interested in that genetic component and genetic predisposition to a disease. So a genetic predisposition, sometimes also called genetic susceptibility, is an increased likelihood of developing a particular disease based on a person's genetic makeup. A genetic predisposition results from specific genetic variations that are often inherited from a parent. These genetic changes contribute to the development of a disease, but do not directly cause it. Some people with a predisposing genetic variation will never get the disease, while other people will, even within the same family. In people with a genetic predisposition, the risk of the disease can also depend on other multiple factors like lifestyle, like environmental factors. Diseases that are caused by a combination of factors are described as multifactorial diseases. So breast cancer and ovarian cancer are a result of both a combination of environmental and sometimes genetic risk factors. As we know from studies that about 10 to 30% of breast cancers and ovarian cancers show familial clustering, but only 5 to 10% of cases are estimated to be hereditary, that is, being associated with a germline variation or a cancer predisposition gene. So it may be that the other approximate 20% of breast cancers and ovarian cancers are due to clusters of certain behaviors, for example. So although a person's genetic makeup cannot be altered, it's very, very important that we consider that some of the lifestyle and environmental modifications, such as frequent disease screenings, maintaining healthy weight, can reduce disease risk in people with genetic predispositions. So that's a hugely important consideration when it comes to genetic predisposition to disease. Many cancers are preventable. Everyone has some risk of developing cancer, and in most cases, cancer developed by chance. However, some people are genetically predisposed to developing certain types of cancers. Although this is often referred to as inherited cancer, what is inherited is the abnormal gene that can lead to cancer, not the cancer itself. Only about 5 to 10% of all cancers result directly from inherited gene mutations. These people have a higher risk of developing cancer than those in the general public. However, it's important to keep in mind that cancer is common. In fact, about 1 in 3 people, it is estimated, in Ireland will develop cancer during their lifetime. So it's not uncommon to have more than one cancer in a family. And sometimes certain cancers, types of cancer, seem to occur more frequently in certain families. In some cases, this might be because family members share certain behaviors or exposures that increase cancer risk, like smoking. Cancer risk might also be affected by other factors like overweight, obesity, and these behavioral factors can tend to cluster in some families. A diagnosis of genetic predisposition to cancer provides opportunities for precision cancer treatment and early detection, as well as prevention of subsequent cancers in patients and their at-risk relatives. So the implementation of routine screening improves the identification and management of pre-symptomatic individuals at higher risk of developing cancer. So it's really, really important that we understand and discover those who have a genetic predisposition to cancer, because these new strategies for intensive screening, risk-reducing medications, or risk-reducing surgeries provide huge opportunities to reduce mortality, to reduce morbidity for individuals with genetic predisposition to certain cancers. And we cannot overstate the importance of lifestyle modifications with respect to diet, with respect to alcohol use, with respect to tobacco use, and we can reinforce these in those with a genetic predisposition to certain cancers. And we know, for example, there are many family cancer syndromes associated with genetic predisposition to certain cancers. Common ones we hear about more often are, for example, hereditary breast and ovarian cancer syndromes, which are linked to the inherited mutation in BRCA1 and BRCA2. We also hear about Lynch syndrome, which is one of the more commonly inherited syndromes that increase the risk for colon cancer. And people with Lynch syndrome are at higher risk of developing colorectal cancer at an earlier age. And Lynch syndrome can be caused by a mutation of any of the several mismatch repair genes, and these are normally involved in repairing damaged DNA. So that's the background to it. So in terms of genetic counselling and testing, these are very complex considerations. So when an individual or a healthcare professional makes a recommendation that an individual partake in genetic counselling testing, there are a myriad of very complex considerations in that. People with a family history of particular cancers face difficult choices. So there is the choice around undergoing testing for a particular gene, a faulty gene. They need to consider how to use the genetic test results. Perhaps these genetic test results can lead to additional surveillance. Perhaps they can lead to additional preventative measures, for example, prophylactic surgery. It also means that the individual will be encouraged to inform and involve other family members who may also be affected by the gene. And we may need to consider fertility and family planning as a consequence of having the genetic testing. However, with an increased understanding of one's cancer genetic mutation, the individual can have targeted screening and targeted prevention strategies, as well as some targeted treatments. And the results of genetic tests are not always straightforward, which often makes them challenging to interpret and explain. So, for example, there is the idea of an unclear result. A gene may have a mutation not linked with cancer risk, and this may have unknown significance. And but we're unsure how that genetic mutation can interact with future environmental factors, and so it's impossible to calculate the risk associated with certain gene mutations. We also know that in terms of cancer tumors, that there can be genetic variation within a tumor. And also we can understand that a negative result means that a specific gene mutation is not present. But that does not mean a person won't have the risk of developing cancer over their lifetime. Their risk is similar to the general population. So they still need to be encouraged to engage in appropriate lifestyle modifications and reduce their environmental exposure to certain things like tobacco, alcohol, etc., similar to the general population. So these are just some of the complex things we need to consider in terms of the decision making around cancer genetics. So the research that I'm involved in is trying to understand, okay, we understand the cancer genetic testing counselling for an individual and their family is important and can lead to very positive decision making around treatments, around screening that can help to reduce the risks and lead to early identification of a cancer. However, we know from the international literature that there are many barriers and facilitators to accessing cancer genetic testing and counselling at individual level, at the health service level, and at the national level. And we know that there are inequalities or disparities among populations in terms of access. So we, together with the Irish Cancer Society, sought to conduct a review of literature where we summarised the results from 122 studies published in the last 10 years, where we tried to identify what were the more common barriers and facilitators to accessing cancer genetic testing and counselling, and what were the common disparities, so that it would inform some current research we're engaging in terms of the Irish context. So in terms of the findings of the review of literature, cancer genetic consultation and access to cancer genetic testing is an important aspect of the care of individuals with cancer. And it's very important that we understand the individual level barriers, and national and service level barriers that hinder access. So hence this piece of research. And it might be difficult to see this, but I'm going to take you through it. These are the individual level barriers, and I understand from the moderator that you can click on the slides if you want to see it more clearly. So out of the 122 studies reviewed, 92 reported different barriers to the accessing of cancer genetic testing and counselling. So the individual level barriers and the most prevalent in the literature was associated with cost of genetic testing. The majority of studies highlighting cost as a concern came from the United States, where we know the health system is different and quite a lot of out-of-pocket expenses are incurred, and there's an unequal healthcare system. And this results in individuals not having access to insurance, and this in turn causes increased costs for genetic testing. Additional important barriers include fear of positive results and fear of their impact on the insurability and employment of the individual. So insurance concerns were factors spoken about quite a lot in the studies that we reviewed. Some people fear genetic discrimination from test results. Others worry about the privacy of their genetic information. But we know that most jurisdictions have legislation that protects against employment and health insurance discrimination, yet that fear exists. Lack of knowledge and awareness was an individual level barrier, and lack of interest regarding genetics testing and counselling. And a very important one was lack of recommendation from a healthcare professional. It's very important when it comes to individuals that come from different ethnic and minority groups. The service-specific barriers included lack of referral, lack of recommendation from the healthcare professional, inconsistency in the application of criteria for referral to the genetic counselling testing services, and insufficient knowledge and awareness of genetic counselling and testing services, both from the genetics point of view and from the service point of view, was something that was articulated by healthcare professionals. There were also logistical and scheduling difficulties highlighted in terms of access from a service level. At a national level, the most commonly reported barrier at a national level was the geographical location of the services and centres, and families in rural areas incurred significant costs associated with travel and time spent going to the centres to have their testing done. And this may add to the perceived excessive cost of accessing genetic testing, and can result in marginalisation of those living in rural areas. Also, lack of genetic services and specialists in genetic workforce is something to consider. So we don't have enough individuals who are specialised in that area of work. A lack of uniform guidelines for specific cancer types, and a difficulty nationally in navigating the healthcare systems leads to systemic barriers. This includes difficulties in tracking appointments and sharing genetic test results without electronic medical record systems being shared. In terms of facilitators, an overview of the frequent facilitators was presented in terms of 81 of the studies reported on these globally. Individual level facilitators included having knowledge of familial history and having proactive health attitudes and beliefs. The idea of family support and responsibility were seen as facilitators. Having knowledge of family history or knowledge of a positive family history was the most mentioned facilitator. And people are generally encouraged to tell family members about test results because they can be important for the health of other family members. But there was also a realization within the literature that it is difficult sometimes with certain family dynamics, that communication piece. But the individual family unit is seen as an important resource in improving access. And their family is important was discussed family's importance was discussed in lots of studies in terms of their role in providing information, support, and social influence around cancer and cancer genetic testing. Shared decision making between the patient and the family and the healthcare professional was seen as a facilitator and a potential positive influence. Other positive facilitators included having a recommendation from a healthcare professional regarding cancer genetic services and screening, living in an urban area, and having insurance coverage. Being younger was also seen as being a facilitator in terms of it was more likely that one would engage in such services. In terms of the services, having national guidelines was seen as an important facilitator, as was having alternative methods to face-to-face engagement in genetic counselling. So having web and telephone access, very important now in the COVID-19 context. Having training, specialist training available for healthcare professionals more broadly in terms of cancer genetics, having access to professional and national guidelines around cancer genetic services, and having awareness of the benefits of having individuals engage with cancer genetic services. These were all seen as very positive facilitators. And in the efforts to streamline access and efficiency of appointments was seen as a positive. In terms of national level barriers, having positive health behaviours among socially influential individuals was seen as a very positive influence. And you might recall Angelina Jolie had a diagnosis of a BRCA1 gene mutation. And it was Angelina Jolie's public announcement of her use of the BRCA gene testing services was cited as a basis for an increase in the overall BRCA testing rates, which became known as the Angelina Jolie effect. Health behaviours among celebrities is often seen to influence individuals' health behaviours both positively and negatively, and has been identified as an important public health issue. It has also been suggested that the influence of celebrities and the media on health behaviours, if it can be regulated and monitored and harnessed for positive use, it can be used to endorse positive health behaviours. So if we can have more celebrity endorsement of certain positive behaviours, well, that can lead to improvements in access to cancer genetic services. Other national level facilitators included engagement in or having national awareness campaigns and having the information available in different languages so that we can ensure equal access to the information. However, disparities are evident among the population in terms of access. A notable body of literature demonstrates that individuals and families from socioeconomically disadvantaged and racial ethnic minority groups are less likely to receive cancer genetic services. The majority of studies highlighting ethnic disparities were based in the US, with individuals from African American and Latino ethnic groups identified as those being most marginalized in terms of accessing cancer genetic testing and counseling services. And advances in genetic and medical technology can reduce as well as exacerbate these disparities in healthcare. And it appears that there are specific subpopulations that are not using the services as much as we would like. And this includes Latinos, Asian Americans, African Americans in the US context. And in the Australian context, Asian Australians, and in the European context, certain migrant groups are less often referred for genetic counselling. These minority groups are impeded by low rates of referral for testing, less familiarity with the healthcare system, and lack of culturally appropriate information. Age disparities are also prevalent. Younger women seem to be more likely to use and access hereditary services compared to older women in several of the studies. And health insurance coverage was seen as a facilitator, but those without health insurance coverage seemed to be less likely to access the services, particularly in the US. There were differences according to education level and differences according to socioeconomic status. So this means that there are certain groups using cancer genetic services less. And we need to be very mindful of this as a society. So in summary, cancer genetic counselling and testing can lead to valuable insights into future disease risk. It can help diagnose cancer much earlier and inform current cancer treatment options. Traditionally, cancer genetic counselling and testing services are provided in person, one-to-one, and only to individuals who meet very strict criteria suggesting they were at risk for hereditary cancer. But we see globally that the models of provision of services are changing to the use of more web-based and telephone-based services in terms of follow-up information and education. And the criteria around which testing occurs is moving and evolving all the time based on new guidance in this area and emergent knowledge in this area. The incidence of pathogenic variants among individuals ranges from 5 to 10% among breast, colorectal, endometrial, pancreatic and prostate cancer, and can be higher in certain other cancers. Overall, it is estimated that many patients, whilst they qualify for testing based on the published criteria, they do not receive it. Yet treatment may be altered as a consequence of knowing more about the genetic basis of the cancer. So it's really important that we ensure that those who ought to have cancer genetic counselling and testing receive such services. So having an understanding of the patient service and national level barriers helps with this. So we need to harness the potential of precision medicine more by taking into account the individual variability in genes, the environment and lifestyle for each person, so that we can ensure that innovative service delivery models such as telegenetics can be leveraged to improve access and ensure access to that individualized approach to cancer care. Education of non-genetic healthcare professionals and providers, and more collaboration with genetic providers to triage patients can increase the reach of genetic providers. And identifying and providing services to minority and underserved communities requires adaptations to ensure optimal access. So these are some of the key messages that are emergent. So if we look at the individual level, we should address cost and fears around insurability and employment. We should increase understanding around those who would benefit most from cancer genetic testing and ensure that that information is cascaded out to the relevant family members as appropriate. So there needs to be a lot of help around communication and communication with different groups. So we know that inherited genetic mutations play a major role in about 5 to 10% of all cancers. Mutations in specific genes are associated with more than 50 hereditary cancer syndromes. So understanding and supporting individuals to access services is important. But also we need to support the services. So we know that, broadly speaking, from other research, that there's a lack of knowledge among healthcare professionals around genetic services and their availability, and sometimes around the genetic basis of certain diseases. So we need to address that. We need to streamline access to cancer genetic services, and we need to address the difficulty in navigating healthcare systems. So from a global perspective, the literature tells us that there's a lack of uniform guidelines. There's a need to exploit the potential of cancer genetics in both prevention, diagnosis, and treatment, but we can only exploit that by having uniform guidance about and implementation of that guidance around access to cancer genetic services. And we need to look at the whole genetic workforce and ensure that we have sufficiently trained and available workforce. We need awareness campaigns, and we need to really address the inequalities in terms of access. There are two pictures here, and this is a picture of some work that's ongoing in terms of the Cancer Genome Atlas, which is a collaborative involving 1,300 scientists and clinicians from 37 countries, where they've analysed the whole genome of lots of different tumour types. And this provides a really comprehensive picture of the molecular biology of cancer and allows us to put technology together with the genetics and bioinformatics, so that we can understand what more about cancer genomics, and we can translate that understanding of cancer genomics into therapeutics with greater potential to develop a personalized cancer treatments to the future. So there's huge potential in terms of that particular project and that global collaboration around cancer genetics. I'm going to do a shameless plug here in that the Irish Cancer Society is working with a team in UCC to understand what are the barriers and facilitators in an Irish context in terms of accessing cancer genetic services. And whilst we understand the global context, we perhaps haven't as much information about the Irish context. So we'd like to know if some of the issues that we have highlighted in terms of the global context actually are issues here or not. So we have put out a call for individuals to partake in either interviews or surveys, and individuals, be they healthcare professionals or patients or members of the public or family members who have experience of cancer genetic services in an Irish context. Maybe there are individuals or healthcare professionals involved in providing cancer genetic services in an Irish context. All perspectives are welcome, and we would love to hear from anybody who has an interest in this area, either by partaking in the surveys that are highlighted here, or by having a conversation with the research team here in UCC. If you want to drop me an email at j.hegarty@ucc.ie, I can give you further information about the study if you're interested in partaking. So we're really trying to understand what's happening in the Irish context, so we can, at least if we understand the barriers, we can seek to address them and understand the facilitators and seek to enhance those facilitators more. So that's, thank you very much. And these are some useful websites that will be up with the information from this session as well, should anybody like to have further information. So thank you. And Fionnuala is coming in. Thank you, Fionnuala.
Hello, everybody. My name is Fionnuala Creek. I'm a daffodil planter nurse in Galway. Thank you very much, Professor Hegarty, for that talk. Very informative. Lots of information there, lots of very interesting information on the barriers, the things that actually go against us looking for genetic information around our cancers. I just have a couple of questions for you myself. You mentioned the inequalities in terms of cancer genetic services. Why is it important that we understand more about the inequalities?
That's a very important question. In other contexts, we know that certain ethnic groups or certain minority groups are accessing cancer genetic services much less. And when that has been researched, it has been found that the healthcare professionals that these individuals interact with don't seem to recommend cancer genetic services as frequently to groups from certain ethnic minorities or other minority groups. And when they do recommend it, it's found that these groups don't take up such opportunities. And it could be that there is perhaps an issue with communication of information or recollection of that information being communicated. And also it could be that once the individual receives information about cancer genetic services, there's a mismatch in that information, in that perhaps it's not culturally appropriate or language appropriate if the person is from English isn't their first language, for example. So the information, it may not appear relevant to the individual. So whilst in many instances in other jurisdictions the recommendation has been made, individuals haven't taken up that recommendation to engage with cancer genetic services. So that has implications for the individual who's been referred, but also for their family. So that's a hugely important area that we need to address. And we know from previous research that the whole area of health literacy is something that we need to consider. So when we're communicating about cancer genetic services, there may not be a perception of this being relevant to the person, so they might not understand the concept. So this idea of abstract terms that they don't really understand the relevance of. So we really need to understand what kind of information works for different groups to encourage them, A, to engage with cancer genetic services, and B, to share that information with their family. Hugely important, particularly around individuals from different ethnic backgrounds, but also from different socioeconomic backgrounds, because we have oftentimes the social inequality, such as increased smoking, increased alcohol use, different behaviours that are associated with increased risk of cancer, compounded by the fact that the individual may not be aware of their increased risk. It's a hugely important area that we need to give a lot of attention to.
Okay, thanks very much for that. There's a couple of questions that I have in the chat area, and one actually ties in with a question that I was going to ask myself in relation to the studies that you're involved in with the Irish Cancer Society. Somebody was asking the question about, does it tie in with research that's been done in other hospitals such as St. James's?
Well, no, this research is just simply being put out there in terms of anybody who's interested in partaking, who it could be a patient, can be family members, can be healthcare professionals involved in the cancer services, or those providing the cancer genetic services. So anybody interested in partaking, it's an open invitation. So it might complement ongoing research, but it's not particularly linked to any other existing piece of research. It's building on the systematic review we've done around what's happening globally around barriers and facilitators, and it's simply trying to understand what's happening in the Irish context, both from a patient, family, healthcare professional perspective. So those that are working within cancer genetic services are absolutely welcome to partake in this research, as are those who are in cancer services more broadly, or those who are experiencing cancer services as both a patient or a family member or a member of the public who has engaged with the genetic services for whatever reason from a cancer perspective. So all participants are welcome, and I think it will help to understand what the experiences are, and then at least we can, if we find something that's unique to the Irish context, it can at least be explored further, or we can seek to address it if it's something that can be addressed from a policy perspective, or from a health service perspective, or from an information perspective.
Thank you very much. Unfortunately, we've run out of time, and I see that there's another question there in chat. So can I just recommend to people that they can contact the support line on 1-800-200-700, and also they can email questions into the support line on supportline@irishcancer.ie. And if you want to look back at the talk that Professor Hegarty has just given, her email is also on the end of that talk. So thank you very much, Professor Hegarty.
Thank you very much.
Thank
and thank you to everybody for listening. Thank you.